Hi, it's Gary Chimes from Lake Washington Sports and Spine, and I was asked to discuss orthobiologic treatments for regenerative medicine treatments for knee osteoarthritis and skiers. So, first off, let me just discuss what is osteoarthritis, and that would be helpful. Let me just draw a diagram of the knee on the board here. So, when we're looking at the knee, this will be the thigh bone or the femur, and then this will be the shin bone or the tibia, and then this is going to be the secondary shin bone or the fibula. So when we're looking at the bone has some cartilage at the end of the bone, and I'm going to draw that in pink, and that's going to be what we call hyaline cartilage. And we divide the knee into three compartments. For the purpose of this picture, I'm only showing two of the compartments. There's the medial compartment, which is the inside of the knee. So if you're dealing with the right knee, it's going to be the left side of the right knee, the part that's closer to the other knee. And then you have the lateral compartment. There's a third compartment called the patellofemoral compartment, which is where the kneecap meets up with the femur. Now, we basically have three different types of osteoarthritis that we tend to see. The first type of osteoarthritis we see is damage to the hyaline cartilage, and that can have different forms. It can be a thinning of the cartilage, where the cartilage just isn't as thick, where it can get worn down. You can also have chipping of the cartilage, where just like a piece of the cartilage breaks off. When that happens, that cartilage breaks off, it tends to stay within the joint space, so you can sometimes have like a floating loose body that can come up from the cartilage. So that's one type of osteoarthritis, would be a loss of cartilage. A second type of osteoarthritis could be what we call a bony osteophyte. And a bony osteophyte, I'll draw that in light blue, could be like a bony overgrowth. Now, bony overgrowths themselves are often not necessarily a problem. They're often an indicator that there's abnormal loading in the knee. So I often have patients ask, like, can we just cut that off? And the answer is you can cut it off, but it's not necessarily problematic. The third type of osteoarthritis we see is going to be what we call subchondral cyst formation. So subchondral, so chondral means cartilage, so subchondral means that the bone that is underneath the cartilage tends to become weakened over time. So you might see like a cyst, you might see like, what we call like a bony edema or fluid in the bone, or you can see like a cyst start to form in the area underneath the bone. And these are all different forms of osteoarthritis. So the traditional treatment of osteoarthritis that we see with what we call like an end stage osteoarthritis is a knee replacement. And a knee replacement is a really excellent surgery. It's one of the best studied of surgeries. They actually have really good registries that orthopedic surgeons use. But there's a couple downsides to a knee replacement. One of the downsides is that it can take some time to rehabilitate. It can be somewhere in the 3 months to a year. And in all honesty, some people do imperfect rehabilitation from it, so they may have some functional limitations related to the surgery. The second thing is that these knee replacements do have a shelf life. They're getting better. It used to be that they lasted 15 to 20 years. We now see somewhere between 15 and 30 years. But, let's say you're somebody who's 42, let's say you get 30 years out of it, at 72, you might be talking about doing a second revision, and revision surgeries are never as good as the first. So, with the orthopedic surgeons I work with, they are often of the mindset that you want to put off the surgery as long as you can with the goal of hopefully doing a single knee replacement. What other options exist? Well, one of the things that can be very beneficial is working with a rehabilitative professional, whether that's a physical therapist or a chiropractor, and that can make a big difference. And people will say, well, I don't understand how exercise is going to regrow the cartilage in my knee, which is true. But what you can do is you can reduce the load that goes across the area where the osteoarthritis exists. So when you're doing, let's say physical therapy, what you might be doing is working on your buttock muscles and your quadriceps muscles. And what happens, let's say you're skiing, when you ski, you push into the snow and the snow pushes back up against you, and that creates a ground reaction force. The ground reaction force during normal walking can be 2.5 times your body weight. With skiing, it can be many times higher than that. So you might be dealing with 500 to 1,000 pounds going upward through your body, and you want to have as much of that force absorbed by your muscles rather than your knee joint itself. So that's part of what you're trying to do with physical therapy. You're also trying to improve like your movement patterns. So people's movements may not be as fluid as they need to be. So by correcting some of those movement patterns, you can have less load going across the joint, which can then make your knee hurt less. But let's discuss the category of orthobiologic treatments. And with orthobiologic treatments, there's going to be two categories that we often use. One of them is going to be something called platelet-rich plasma, which is sometimes we will call that PRP. And another one that we use fairly frequently is micronized fat, and there's something we call lipogems. And the idea behind these treatments is that they are designed to augment the natural healing response that your body naturally has. So when we think about orthobiologic treatments, let's just think about how the body normally heals. You cut your skin, how does that cut heal? Well, one of the ways it happens is that blood comes to the area, and that blood is going to contain a bunch of stuff. It's going to contain red blood cells, which carry oxygen, white blood cells that fight infection, but it also has platelets, and not just the platelets, but the things that aggregate with the platelets, and that's going to be the stuff that induces your healing response. So if we can bring that into the area of injury, that can help augment the healing response. And PRP is great. We really have had excellent success with PRP as a treatment option. Now, there's something that you can kind of step it up a notch, and then there's something called Lipogems, and I'll make a link to the Lipogems for a case with knee osteoarthritis. The idea behind Lipogems is that your fat cells or the adipose cells in your body, they got more juice. They have more stuff in them that can help with healing. Another thing that's really great about Lipogems is that it's more viscous. It looks like a lemon curd. So what we do is we do a fat grafting procedure that's pretty similar to what you would do for a liposuction, although we're not doing it for cosmetic reasons. But we find that people don't really mind losing a little fat off their midsection. And then we process it through a micronizing process, which is basically going through a canister with metal BBs. And what we're left with looks like lemon curd. And it can really be quite effective. We actually have seen, for example, cartilage regrowth. So it's not just making the cartilage healthier, but it can actually regrow some of the tissue. And these are really great options to consider. So looking at my list of questions of things that people want to know about is when would be the situations would surgery be a better choice? I don't know that surgery sometimes is the right choice after you've tried other options. There's not an obvious situation where I would say to somebody, you absolutely have to go to knee replacement and you're just wasting your time with all this other stuff. What I will say is with osteoarthritis, we often grade it as things like mild, moderate, and severe. And no matter what treatment you're talking about, mild osteoarthritis responds better to the treatment than severe osteoarthritis does. So if you look at, let's say physical therapy as an option, physical therapy is more effective for mild knee osteoarthritis than it is for severe. But you see many people who rehabilitate very effectively with severe osteoarthritis with physical therapy. So I wouldn't say to somebody, if you have severe osteoarthritis, don't bother with physical therapy. Similar orthobiologic treatments can be quite effective. And I've seen people who have severe osteoarthritis who respond very well. So there's really no subset of patients for whom orthobiologics are a bad choice. But just know that your success rate is going to depend on your demographic characteristics. And so beyond the severity of osteoarthritis, the things that actually drive a lot of the decision making are going to be personal characteristics. So older people don't do as well as younger people. People who are obese or overweight tend to do worse than people who are of a leaner body weight. People who regularly engage in exercise do better than people who don't regularly engage in exercise. People who take non-steroidal anti-inflammatories like ibuprofen, Advil, Aleve, they tend to do worse because they inhibit the natural healing response. Smokers tend to do worse. Diabetics tend to do worse. People who don't get enough sleep tend to do worse. So just anything that is going to affect your body's natural healing capacity will affect you. But that's going to be true for any treatment option, including surgery. Another question is, are there times that, we discuss the different types, we discuss the different alternatives. I guess the final thing I'll discuss is just, are there any specific issues related to skiers to keep in mind? What I would say with skiing is that there's a few things you always have to keep in mind. It's, the type of loads that you need to do in skiing are going to be quite high. And that's why I think that these orthobiologic treatments or regenerative medicine treatments, it's really a good idea to do that to build on the benefits you're getting in physical therapy or chiropractic care, as opposed to using it as an alternative. Other things to keep in mind is that when you're dealing with skiing, you have to account for the loads of the skiing itself, and then you have to account for the loads associated with things not going according to plan. So skiing, more than some other sports, you're going to have aberrant events. These are going to be both intrinsic and extrinsic. So intrinsic aberrant events are things like you misjudge the snow and you take a turn more aggressively than you were expecting. An extrinsic event would be somebody behind you is being a spaz and they run into you. So those are things that you have to pay attention to. So I think the principles are pretty similar for skiers as other patients, it's just more so. So I hope this is helpful for people, for skiers who are thinking about orthobiologic treatments for the knee. Thanks. Gary Chimes, Lake Washington Sports and Spine.